This is my second video on blood coagulation and control for cellular molecular medicine. The learning objectives are to explain the anticoagulant functions of aspirin and Plavix, describe the role of vitamin K and how warfarin inhibits vitamin K function, explain how INR values are used to manage warfarin dosages, describe the role of genetics in warfarin metabolism, tell where heparin comes from and how it works as an anticoagulant. Aspirin and platelets. Aspirin is a psilocybin inhibitor of platelet cyclooxygenase 1, also called COX-1, that produces thromboxane, which causes vasoconstriction and activates more platelets. Aspirin irreversibly inactivates COX-1, and it also inactivates COX-2, but platelets only have COX-1. Consequently, taking aspirin slows clotting. Plavix, or clopidogrel, is a drug used to slow clotting in patients with coronary artery disease by preventing platelet aggregation. It prevents ADP, adenosine diphosphate, from binding to a receptor in platelet membranes, which is important for platelet aggregation. So here's a little picture of a platelet plug being formed here, and you can see ADP up there, and thromboxane's needed there, made there too. So the platelet has little granules in it as well, and that's COX-1 makes the thromboxane. And then aspirin prevents that from happening, and so you don't get the platelets activated, you don't form the platelet plug as rapidly, and so the ADP activated platelet doesn't form because aspirin prevents that process from occurring and slows up the whole deal, and so he slows clotting. And then von Willebrand factor also helps to bind the platelets to the collagen at the site of damage. And fibrinogen and endothelial cells are involved in this as well. We'll talk more about those we have as well. Gamma carboxyglutamic acid, or GLA residues. These are pictured here. These proteins are made in the liver, and they have one carboxyl group on them on a side chain of glutamic acid, and vitamin K dependent process puts an extra carboxyl group on there, and that extra carboxyl group allows the clotting factors such as 2, 7, 9, and 10 to organize at a placement where it's phospholipid membranes and platelets are, and calcium will cross-link this, and that keeps the clotting factors in close contact with each other, so they speed things up and accelerates the process, making it work a lot better. So if you don't have this, if you can't form the GLA residues, it slows the process down a lot, and so it inhibits clotting. So vitamin K is required to put those carboxyl groups on, and warfarin inhibits this process, and I'll talk about how it inhibits in a minute. So this is historical. Cows fed spoiled sweet clover developed hemorrhagic disease, and it was called, originally discovered, vitamin K was discovered in Scandinavia by Danish scientists, and they call it vitamin K because they spell coagulation with a K. And later it was the compound dicumarol was found in spoiled sweet clover, and eventually the Wisconsin Alumni Research Foundation, people were working there on cows because in Wisconsin they raise a lot of cows, and they were dehorning their cows, and they were dying from the dehorning. And so they worked this out and figured out what was in the sweet clover, the spoiled clover, that was causing it, and that resulted in the creation of this new drug called warfarin, which is a great rat poison, and it's also used to slow clotting in people. And so it's called warfarin based on Wisconsin, WARF. That's how it got its name. Vitamin K and warfarin. So warfarin doesn't inhibit vitamin K directly. It inhibits the reductase required to keep vitamin K in the reduced form. So we need reduced vitamin K to put that carboxyl group on there, and warfarin, and there's a reductase that uses NADH to NAD that takes the oxidized vitamin K from this reaction and reduces it. So activatable prothrombin, so these are the factors that all have gamma carboxyglutamic acid on them. Added carboxyl group, negative charged phospholipids, and it binds. This is a plot of the incidence of platelet patient years here and adverse events here. And you can see there are far more adverse events. You get a lot of bleeding if you have an INR that's low, and you get clotting if you have you get a lot of clotting if you have an INR is low, and you get a lot of bleeding if you have an INR is high. So increased clotting with a low INR and decreased or increased bleeding with a high INR. So normally we're about 0.9 to 1.3. Quite often when people are put on, patients are put on warfarin, their target dose is to try to get them around 2 to 4. So right in this range is the INR target that's used. And it's measured by the prothrombin time. The ISI or fudge factor, the ISI here is the fudge factor, International Standardized Unit, is the normalized differences in prothrombin preparations in various places in the world or wherever it's made for that time for doing this work. So remember, this is the way it happens. Warfarin pharmacogenomics, cytochrome P450 genetic polymorphisms. Warfarin is metabolized by cytochrome P450s. Warfarin is a racemic mixture of R and S enantiomers. S-warfarin is responsible for 60 to 70% of the anticoagulation response. R-warfarin accounts for 30 to 40%. S-warfarin and R-warfarin are metabolized by different P450s at different rates, genetic variations in the P450s. Very slow P450 might have a 1/2 normal Vmax or 1/2 normal Kcat. A slow P450 may have a 10 times normal Km. So these variations can affect how fast it's done. Numerous P450 variations, there are approximately 26 known at present. So here's a plot of drug levels and days on your patient. If they're a very fast metabolizer, you may never get them up to the effective dose. If they're normal, they get it fine. They may be slow metabolizers and they slowly get up to toxic doses, or if they're very slow metabolizers, you'll have a toxic dose pretty quickly. So you've got to watch that and not give them too much. So fast P450 enzymes, slow P450 enzymes. Now, warfarin and diet. Warfarin can be affected by your diet. So leafy greens such as spinach, cabbage, parsley, and avocados increase the amount of rich in vitamin K. And vitamin K, remember, is fat soluble. So consequently, if you add oily salad dressings to your spinach salad, you'll get a lot more, about 10 times more vitamin K. This can interfere with your warfarin therapy. So if somebody's been on the normal, got their just dose of warfarin, and suddenly they decide they're going to eat spinach salads every day, they could get in a little trouble there. Intestinal E. coli also make vitamin K. The gut flora affect vitamin K levels, and antibiotics can lower vitamin K. Vitamin K capsules lower INR if it gets too high, so you can take capsules for it. Slowly, liver makes new clotting factors. So it's not a very fast process to reverse this because it takes a while for the liver to synthesize those new clotting factors. Antithrombin 3 or heparin. So this is heparin, and heparin activates antithrombin 3, which is the blood plasma serine proteinase inhibitor, SERPIN, just like alpha-1 antitrypsin. Heparin is found on the endothelial cell surface. I've talked about that. But heparin comes from pig intestinal mast cells. And here's a pig intestinal mast cell, our human mast cell over here, EM of that. You can see a lot of granules in it. So here's the way it works. Jim Huntington at Cambridge provided this video for me. It shows how antithrombin 3 is a heparin-activated SERPIN. And you can see the heparin binding to the antithrombin 3, and then the reactive site loop comes out, and then it can be cleaved by the protease and get trapped. And you can see how it gets trapped over here because the thrombin comes down, hits that, cuts that place where the arginine is, and then the thrombin gets caught and twisted around and denatured so that it's no longer functional down at the bottom. It gets dead. And so it makes this complex, and that's it. So thank you very much. Hope you enjoyed that. Bye.